Hi all, it's Gavin Greenfield here. This is a slightly updated version of this video from what you saw in your December 2020 e-learning. And one of the main updates is just to review who gets into the brain injury protocol. So if we go to our critical care MCPs and we navigate to the universal, we'll scroll down and we'll see brain injury, yes. And who gets into the brain injury protocol? Traumatic head injury with an alteration in GCS is the one patient population I think we commonly think of with respect to this protocol. But don't forget about the suspected brain injury due to a non-traumatic condition with an alteration in GCS. Somebody with a mass or a stroke or maybe a hypoxic brain injury. Those patients would fall into this protocol as well. So with that, let's carry on. For this video, you may want to follow along with your actual own CCMCPs on your phone or on your computer. The font that shows up from the CCMCPs that we display in this video is a little bit small. Good morning, everybody. Gavin Greenfield here, transport physician out of the Calgary Basin and the Director of Education. And I'm joined on the line by Shell.
Good morning, everyone. Shell Ryan, one of the central educators out of the Edmonton base.
And we are here today to speak with you about the brain injury mechanical ventilation CCMCP. So just as a reminder, here's the website, how to get to our AHS EMS protocols. And if we click on critical care MCPs and we go over here to respiratory, and then mechanical ventilation mechanical, and then we'll go to the brain injury, and it takes us to here. So, Shell, why don't you start us off with this box here?
Absolutely, Gab. So these are pretty standard settings that you'll notice. So the brain injury initial ventilation settings are mode is volume controlled ventilation or pressure controlled ventilation, PRVC. So for us, that would be the Hamilton T1, which is the CMV plus. And for any other volume control, that may look like assist control on your own vent. Rate is 16 breaths per minute. The tidal volume in 8 mils per kilo for ideal body weight. FiO2 start at 1.0. PEEP +5. And IE ratio is 1 to 2 or less. Now this was a change from our last CCMCPs. Remember, 1 to 3 is still less than 1 to 2 as a ratio.
Great. And just one point of emphasis, you'll notice ideal body weight. This is, of course, in all of our protocols and why it's important to carry a tape measure so we can get an accurate estimate of ideal body weight. Let's move over to this box, patient safety considerations. So we know that hypoxemia and hypotension in patients with brain injury is bad, both associated with increased mortality. And we're going to do whatever we can to avoid those two situations. After that, we can turn our attention to CO2. And we think that tighter control of the arterial CO2 is better for patients, and there is some literature to support this. And this comes back to some physiology. When we hypoventilate somebody and cause hypercarbia, we increase cerebral blood flow, and this may increase intracranial pressure. And the other side of that is hyperventilating, which causes hypocarbia, which causes cerebral vasoconstriction and may impair blood flow to the brain. Both of these are potentially bad in patients with brain injury. And we know, you recall years ago, we often hyperventilated many of these patients, and we really think that that's detrimental, especially if they don't have a herniation syndrome. So tight control of arterial CO2 we think is a good secondary goal after this primary goal of avoiding hypoxemia and hypotension is met. So with that in mind, Shell, why don't you take us over to our CO2 goal box, which is right here.
So our CO2s, like Gav just said, are important. We're trying to gain control of the arterial CO2 in particular. So arterial CO2, if you have an arterial gas, then you really want to ensure that we're titrating the arterial CO2 between 35 and 40. And again, this is in the non-herniated patient. Our end tidal CO2 goal is 33 millimeters of mercury or less. So your end tidal, we get that to 33 or less. And our venous CO2 goals are 42 millimeters or greater. And this is just due to the normal differences that you're going to see between the normal gradients of 2 to 3 between. But this gradient can be quite wide in anybody who has shock or poor perfusion. So Gab, those are our goals. If you have an arterial blood gas, then that's the target that we're aiming for. If you don't, then we're going to get into bracketing, where we're going to bracket the end tidal, which is going to be the lowest value, and your venous, which is going to be your highest value.
Exactly. With that in mind, let's just take a quick move over to the notes section. And you'll see if you scroll down on the notes section here, we talk about the stepwise initiation of this. And so it's right here. And as Shell mentioned, this is our sort of normal gradient. So the end tidal CO2 typically will read somewhere between 2 to 5 millimeters less than the arterial CO2. And the venous CO2 in healthy patients is about 2 to 5 millimeters of mercury higher than the arterial CO2. So this is where bracketing comes in. This is going to be a little bit lower than the arterial CO2. This is going to be a little bit higher. Now, when I say a little bit, that changes. When we have a lot of physiologic dead space, as identified right here, the end tidal CO2 will read lower than this 2 to 5 millimeters of mercury gradient. And when there's a lot of shock or poor perfusion, the venous CO2 will be higher. But the relationship still stands. The venous CO2 is the highest value, the end tidal CO2 is the lowest value, and the arterial CO2 falls somewhere in between. Now, I will just say you will rarely see this relationship not hold true, and this is has a little bit to do with VQ mismatch primarily and dead space. But occasionally you will see values where this relationship does not hold, and authors have described this in the literature, but it's very rare, and for our purposes, it's not applicable. This relationship holds true in 99.9% of the patients that we're going to see. So with that in mind, let's go back to the actual protocol. And we'll move over here. And so again, the evidence Shell talked about, arterial CO2 is the parameter that we're trying to get between 35 and 40. And we use the end tidal and the venous to bracket that value, because often we don't have an arterial value available to us. And we just talked about how those gradients work between the end tidal and the venous. Now, regardless of what you're doing, if we come over to this box, step one is still always going to be this. Even if you have access to an arterial value, you know the arterial value is going to be higher than the end tidal. So even before you draw an arterial gas, get that end tidal to 33 or less. And so if it's 33 or less, then you can go on and draw either your arterial or venous sample, whatever you have available to you. But if it's greater than 33, you know the arterial value is going to be high, so then ventilate them by increasing, we say 2 breaths per minute at a time, to get that end tidal CO2 33 or less. So Shell, do you want to take us maybe down to the signs of herniation and talk about what those signs of herniation are, and then how the ventilation parameters change or goals change slightly?
So signs of herniation, that's something that's changed throughout the last few years as well. So what's out there now as signs of herniation are just as they are on the CCMCPs. So the signs of herniation, let's go to the signs of herniation. Gab, do you want to take us through that note section just so we can see what that looks like?
You bet. So here's the notes on the signs of herniation here.
So when we're talking about signs of herniation, one of the things that we're looking for is the patients will always have a low or rapidly declining GCS. So we've added the rapid declining GCS because if you have a patient who currently has a little bit higher GCS and their GCS is declining pretty quickly, so they've gone from a 14 to a 12 and they continue to decrease, that would also meet in this definition. In addition, they need one or more of the following. So notice it says one or more. So they can have both or they can have just one. So abnormal pupils is the first one. And both pupils are non-reactive, or one or both pupils are dilated. So they're just talking about the pupils are abnormal and the patient has a low GCS. They would fit into herniation syndrome. The second part to that is abnormal motor. So if the patient is posturing, and it doesn't classify what type of posturing, if they're either decorticate or deceborate posturing, that falls into this category as well. So you need to have the low GCS or rapidly declining and one or both of abnormal pupils or abnormal motor exam. So if your patient meets these definition, then we are going to kick over into the herniation goals.
Yeah, and they're here, or we can go back to the algorithm. What's your preference, Shell?
Yeah, let's go through here since we have them. So if the patient meets those definitions, then we move into the hyperventilation. So our CO2 goals change a bit. You'll notice they don't change a lot, they change a bit. So your target PaCO2 is 32 to 35. So if you recall before, it was 35 to 40. We've just moved it down a little bit to be at the low levels of the arterial CO2. So 32 to 35 is our gold standard for arterial. However, in our world, if you are unable to get an arterial sample at that time, or you're unable to at all, we're going to then go ahead and bracket again. So Gab, do you want to walk us through the bracketing?
Yeah, and Shell, just so there's no ambiguity, even if we have access to an arterial sample, we're still going to do this first, right? We still want to get the end tidal to our goal before we draw that sample, because if the end tidal's high, we already know the arterial is going to be high because of the bracketing. Is that's right?
Yeah, absolutely, Gab.
Okay.
Thanks for pointing that out. So the end tidal, our goal then, you'll notice our end tidal goal has slightly moved down, our arterial goal has slightly moved down, and our venous goal has slightly moved down. So step one, obviously, since it's the most available, is that end tidal for sure. So you want to get that to 30 or below.
Yeah, and that just follows the gradient, so that as we discussed above, with a normal gradient being somewhere like 2 to 5. So once we get that 30 or less, then we draw the blood sample, whether that's an arterial or a venous sample. If you have access to an arterial sample, then we would recommend drawing that in this scenario, because that is the actual, that is the gold standard. That is what we're trying to target, this 32 to 35. If we don't have access to an arterial sample, we're going to draw a venous sample, and then we're going to bracket. And note that our venous goal is 3 lower, just like everything else. It's moved down by 3. And so if the end tidal is 30 or less and the venous is 37 or greater, we're done. We're done. We know the arterial is going to be somewhere in between those two parameters, and we're not going to change ventilation at that point. So I think that's what our goals in the non-herniating patient and what our goals are in the herniating patient. So let's go back to the algorithm. Oh, one more thing we've mentioned here. If the brackets are wide, so if you meet these parameters and you've got an end tidal, let's talk about the herniating patient. If you've got an end tidal that's 29 and you do your venous and the patient's really sick and in shock and the venous is 80, well, the algorithm would tell you to not change ventilation, and that's appropriate. But you have no idea. You just know the arterial is going to be somewhere between 30 and 79, but it could be anywhere in there. So when the brackets are wider, and we a bit arbitrarily choose 10 as a number that will define narrow versus wide brackets, if the brackets are greater than 10 and you can do an arterial sample, we would recommend trying that in the brain injured patient.
Mm-hmm. And this is the hardest one to wrap my head around. You have an end tidal that's really low, and you have a venous that's really high. But I think, like you were saying, Gab, like the point to note is we have no idea what the arterial CO2 is. We don't know if it's closer to the end tidal. We don't know if it's closer to the venous. It's somewhere in between those. That's why it's so important to bracket, but it's also one of the hardest ones to get your head kind of wrapped around for me, Gab.
I totally agree, and it really depends on sort of how much dead space versus shock, and of course these coexist. You know, shock causes physiologic dead space, so it's tough. But what we want to avoid is chasing one number in isolation, chasing a venous CO2, chasing an end tidal CO2. We want to avoid that, and again, use those as your brackets. Your venous is going to be the highest value, your end tidal is going to be the lowest value. So let's go back to the algorithm, and we've talked about hyperventilation. And once we're happy and we've got our ventilation where it needs to be, we simply turn our attention to the FiO2 and decrease as needed to maintain SATs in that 94 to 97 range, and continuing transporting back to home. So I think that's it, Shell. Is there anything else, any other points you'd like to emphasize?
I think the only point I have left to emphasize is that CO2 control, again, is just super important in these patients. And also treat concurrently, as you say there, with a head injury protocol, just to ensure that we're doing other things for this patient as well. As with the same in all the respiratory mechanical ventilation protocols, it'll always say treat concurrently with what's medically going on.
Okay, great, thank you. And I guess there's one more point I want to emphasize. We have right in the algorithm here, avoid hypoxemia and hypotension. If we go back to the notes, hypoxemia and hypotension are grouped together as oxygenation. So remember, the primary goal is adequate oxygenation. However, oxygenation incorporates both SATs as well as oxygen delivery, so cardiac output, blood pressure. So that is oxygenation. And when we talk about right here in the adjustments, again, the first one is adequate oxygenation. So we need adequate SATs, but we also need adequate blood pressure, and this section discusses that. That is priority one. Once we're happy with that, we can turn to this bracketing and CO2 discussion. So I think that's it. Thanks, everybody, and we'll talk soon. Thanks, Shell.
Thanks, Gav.
Thanks for your attention, all. If you have any feedback on this video, please provide it to both Shell and myself, and or either one of us. And if you have any feedback on any of the CCMCPs, an email will pop up on the screen here directing where you can send that feedback. Thanks very much.